Kulkarni, Professor and HOD at Kasturba Medical College, Manipal.
Hello.
Let us welcome Dr. Malavika Kulkarni to deliver her talk on brain death and organ retrieval, the final beat.
I'd rather say very good afternoon, everyone. So at the beginning, I would like to thank the organizers of ISACON Karnataka 2025 for giving me this opportunity. And thank you for the kind introduction. So can I know how many of you have anesthetized an ASA6 patient? Any raise of hands? Okay, that's quite encouraging. So the topic for today is on brain death and organ retrieval, the anesthetic management of an ASA6 patient. I'll quickly walk you through the objectives of this presentation. They are as follows. So as you can see, one organ donor can save several lives. And this is very crucial because there are many awaiting for a transplant. Therefore, one act of generosity can give a second chance to several patients. Hence, organ donation is important. So every 10 minutes, a patient gets added on to the transplant list. But the paradox is that there is a marked mismatch between the organ supply and demand. So there are several lakhs of people in India who die awaiting for a transplant. If you see the performance of India in terms of deceased organ donation, it's quite dismal. It's just 0.8 per million population when compared to Western countries like Spain and USA. Coming on to the Transplantation of Human Organs Act, which was introduced in 1994, this legalized brainstem death and brought in regulations for organ donation so as to prevent trading of organs. Subsequently, this act went through amendments in 2011 and 2014. In 2023, the age limit for recipients was taken off, so also the free registration was permitted across the states. The extended donor criteria has been introduced so as to increase the organ pool. So this is with age of patients more than 60 years, those with controlled comorbidities, as well as donations following circulatory death. There are absolute contraindications for this. They are those patients with multi-organ failure from severe sepsis, those with active transmissible cancers, active transmissible infections of viral, bacterial, fungal, parasitic origin. So, coming to the crucial definition of brainstem death, which forms the foundation for organ donation. So this is a stage wherein all the brain functions have completely and irreversibly ceased. So this comprises of three components. They are irreversible coma from a known cause. The second aspect is the brainstem areflexia, and the third one is a positive apnea test. So where does the role of an anesthesiologist lie? The anesthesiologist is responsible for certification of brain death. However, the same anesthesiologist is not in the organ retrieval team. Now, coming to the clinical criteria, first and foremost, it is necessary to rule out the reversible conditions. The reversible conditions are those with acid-base, electrolyte, metabolic, endocrinal abnormalities, those with toxic or those on sedative, muscle relaxants, or any drug poisonings, those in hypocirculatory states, hypothermic, and those patients with neurological conditions such as GB syndrome, locked-in syndrome, encephalitis, all this has to be ruled out. Absence of pupillary reflex, corneal reflex, oculocephalic reflex, oculovestibular reflex, and absence of cough and gag reflex on the stimulation by the means of suctioning of the endotracheal tube, along with the absence of motor response to pain. So this is the second criteria that establishes the brainstem death. Now, once these two criteria are satisfied, the next component is the apnea test. Before going ahead with the apnea test, there are certain prerequisites, and they are the patient should be normoxic, a saturation of more than 95% with a PaO2 of more than 200 millimeters of mercury on a FiO2 of 1. Patient should be normotensive with a systolic pressure of at least 100 millimeters of mercury on vasopressors. Patient should be normothermic, normovolemic, normocapnic. A baseline ABG is necessary to establish the CO2 levels. So the apnea test is necessary to confirm the absence of a spontaneous respiratory drive. Here, the patient is pre-oxygenated for 10 minutes with 100% oxygen, following which the patient is disconnected from the ventilator. A catheter is passed through the endotracheal tube and retained at the carinal level, and 100% oxygen is administered at 6 liters per minute, along with the monitoring of hemodynamics and respiratory effort. So the positive result is absence of any spontaneous breathing efforts associated with a PaCO2 level of more than 60 millimeters of mercury or more than 20 millimeters of mercury from the baseline. So this apnea test is repeated twice at an interval of 6 hours. And the second apnea test is taken as the time for establishment of the brainstem death. So legally, the patient is brain dead here. So there are certain ancillary tests which are done when the brainstem death is inconclusive from the apnea test or the apnea test has been aborted, of which the 4-vessel digital subtraction angiography is considered as the gold standard. There are others like transcranial Doppler, CT angio, MR angiogram, and the radionuclide perfusion scans, SSCPs, EEG, all are contributory to the clinical criteria. Moving on to the pathophysiological changes. So the cerebral ischemia brings about vicious cycle, wherein what happens is that once cerebral ischemia sets in, it proceeds in a rostrocaudal fashion, and it moves from the cerebral hemispheres to the pons, wherein it manifests as Cushing's reflex. Then, when it moves on to the medulla oblongata, the cerebral ischemia brings about an exponential release of catecholamines. So there is a catecholamine surge when the medulla oblongata is involved, which mimics a sympathetic storm, leading to hypertension, tachycardia, and tachyarrhythmias. Subsequently, when the spinal cord gets involved, this leads to a deactivation, leading to vasoplasia, hypotension, and circulatory collapse. So why is this important? Because all these reflect on the organ systems in the body. So if you see the pathophysiological changes, multiple organ systems are affected. The myocardium is the first to get the brunt, and the hypertension, tachycardia causes myocardial damage. Now if you see, it is a culmination of many shocks. The neurogenic shock, cardiogenic shock, and the hypovolemic shock form diabetes insipidus. Now, the myocardial injury results, and this can lead to LV dysfunction. Initially, in the critical care unit, this patient is supported with fluid resuscitation. Once the patient is not responding to fluid resuscitation, then the vasopressor support is initiated. Generally, the first line of support is vasopressin. However, other vasopressors such as phenylephrine, norepinephrine, or epinephrine can be initiated. If there is any LV dysfunction, dobutamine can also be introduced so as to maintain hemodynamic stability. Now you should remember that the priority is organ perfusion and not cerebral resuscitation, so the whole focus is shifted. Besides, invasive monitoring is also commenced with CVP monitoring, as well as the invasive arterial access to do the beat-to-beat monitoring for repeated ABGs, as well as to assess the systolic pressure variation, pulse pressure variation, which are necessary to know the fluid responsiveness. Next is the brunt is borne by the lungs, wherein there is a neurogenic pulmonary edema, the increased capillary permeability, which leads to the exaggeration of pulmonary edema. This is handled by the management with the help of a lung protective ventilatory strategy. So the effects are further translated to the hypothalamus and the pituitary, wherein these patients behave like poikilothermics. And the posterior pituitary is the first to be affected with the reflection in the form of a central diabetes insipidus characterized by dilute urine and hypernatremia. The anterior pituitary, when it gets affected, it manifests in the form of reduced release of thyroid hormones, hypocortisolism, and reduced insulin secretion leading to hyperglycemia. So hyperglycemia is because of insulin resistance as well, and due to the gluconeogenesis that takes place. Coagulopathy is another manifestation, and this is because of the release of the tissue thromboplastin as well as the tissue plasminogen activators from the necrotic brain. So it is very important to make arrangements for blood and blood products when these patients are posted for organ retrieval. One more manifestation that is quite disturbing is the involuntary movements that occur because of the reflex spinal arc. Now the spinal cord is still active, but it is not controlled by the brain anymore. And one of the predominant signs is the Lazarus reflex, which actually mimics a grasping kind of motion, which is seen in about 40% of the patients. So this can be disturbing to the caregivers as well as the patient families and cause a major confusion regarding the establishment of brainstem death. This is handled by the administration of neuromuscular blockers. So this is the hormonal therapy that is initiated in the intensive care unit. Now, if the patient is hemodynamically unstable, then vasopressin would be the treatment of choice because central diabetes insipidus is also present in about 80% of the patients. Subsequently, the insulin is also required to maintain a blood sugar between about 80 to 180 milligram percent so as to facilitate the graft function. And methylprednisolone is necessary for anti-inflammatory effects as well as for hemodynamic instability. There is a lot of confusion with respect to the thyroid hormones, whether it is beneficial or not beneficial. However, in our institute, if the patient is not maintaining any hemodynamic stability, in such situation, enteral levothyroxine is administered through the nasogastric tube. So these are the organ donor management goals, which is famously known as the rule of 100, which all of you need to remember. The systolic blood pressure of more than 100 millimeters of mercury, a PaO2 of more than 100 millimeters of mercury, urine output of more than 100 ml per hour, and hemoglobin of around 10 gram percent, blood sugar levels of 100 milligram percent. These are the targets that need to be set. So once this patient is decided to be an organ donor, then the anesthetic team comes into action. And here, the anesthetists come and evaluate this patient with history and physical examination, ask for the necessary investigations. Many of these investigations may need to be repeated every second or fourth hourly, like the ABG. If there is any LV dysfunction, serial echoes may be required, and the patient may even require a coronary angiogram. It is important to note the core temperature. As I told you, they are prone for hypothermia, as well as the urine output, to note that if the urine output is more than 4 ml per kg per hour, it is suggestive of central diabetes insipidus. Blood is an important aspect. As I already discussed, it needs to be arranged. Blood and blood products are integral. Now, documentation is very important, and the brain death has to be certified and authorized. So certification of brain death is by Form 10, and authorization by the kith and kin is by Form 8. So the number of organs that are going to be retrieved also need to be mentioned. The patient is transferred from the ICU to the operating room with the lines, invasive lines in place, with the infusions going on ventilator, and a muscle relaxant administered. So this is the Form 8 and 10, which is introduced by the government of Karnataka. Moving on to the preparation in the OT, this is managed like any other major case. There is a requirement for a large operating room, and active warming measures should be in place. Along with the standard monitors, the invasive arterial monitoring and CVP monitoring should be continued. In case of any LV dysfunction, the PAC catheter is also introduced. Now, next is regarding the fluids. The balanced salt solutions are the fluids of choice. Starch-containing colloids are generally avoided. Blood and blood products should be arranged. So what is the role of anesthesiologist here? The primary role is basically the suppression of the spinal reflexes and to blunt the hemodynamic responses, improve the surgical condition, and organ preservation. This is the key in the anesthetic management. So let's see how this is facilitated. So the incision here basically is a sternotomy laparotomy incision commencing from the suprasternal notch to the pubic symphysis. The organs are basically dissected and mobilized. During this period, the following goals are managed in the intraoperative period, wherein A mean arterial pressure is maintained about 60 to 80 millimeters of mercury, the central venous pressure of about 6 to 10 millimeters of mercury, and the pulmonary capillary wedge pressure in LV dysfunction to about 8 to 12 millimeters of mercury, followed by a cardiac index of 2 to 2.4 liter per minute. Along with the lung protective strategy of ventilation, the goal is to maintain a minimum FiO2 with a saturation of more than 95% with a PEEP of around 8 to 10 centimeters of water so that the peak inspiratory pressure doesn't exceed 30 centimeters of water. So these are the anesthetic drugs, fentanyl and the inhalational agents for suppression of hemodynamic response. And the inhalational agents also facilitate the ischemic preconditioning, vecuronium for suppression of the involuntary movements. Heparin is administered at 300 international units per kg on the suggestion of the surgeon. Then the SVC, before it is ligated, the central venous catheters and the PAC catheter need to be withdrawn. And once this is done, once the aorta is clamped, that is taken as the time for the cold ischemia time. And following this, the organs are retrieved in the following manner. The heart and the lung are the first to go, followed by the liver, pancreas, intestine, and the last one to be the kidneys. So if the lungs are planned to be retrieved, then the lung recruitment is done prior to the disconnection from the ventilator. The ventilator is further disconnected and the anesthetic care ends here. The abdominal surgical team continues to operate in circulatory arrest. So here we have a human organ which is available now for the recipient. So the take-home message of this presentation is that early identification, WIPS-based management, ethical safeguards maximize the potential brain-dead donors. This increases the organ availability, improves the graft outcome, keeps the transplantation life-saving and ethically sound. Thank you for your kind attention.
Thank you, ma'am, for that moving and clinically grounded presentation.